Okay, now we will be studying the external configuration of the heart. So in this specimen, you can see a heart that maybe belonged to an individual who was probably like an athlete or something related with sports because it looks quite big. We have the sternocostal surface or anterior view, and recalling the anatomical axis of the heart, remember that the heart's anatomical axis goes from right to left, from back and forward, and from top to bottom, alright? Here you'd have located on the left ventricle the apex of the heart, which if we projected it to superficial anatomy would be found at the fifth intercostal space, medioclavicular line on the left side. Here you'd have the base of the heart. This heart space, it's going to be looking up, to the back, and to the right. And it's related to which thoracic vertebrae? From T5 to T8. Of course, these relations vary depending on whether our subject is standing up or laying down during inspiration or expiration. Some authors state that it goes from T6 to T9. We're going to leave it from T5 to T8 for now, okay? So, the sternocostal surface of the heart gets its name because it is related with both sternal and costal cartilages. And here the first thing that calls your attention is the sulcus. This is the interventricular anterior groove, where the anterior interventricular artery goes over. You can also observe that this groove ends on the right side of the heart's apex, and it's separating the left ventricle from the right ventricle. And you're also seeing that this sternocostal view is formed mostly by the right ventricle, while the so to say left border is formed by the left ventricle. So this would be the interventricular groove. And just at this level is where profoundly you'd find the interventricular wall separating the right and left ventricles. If we go up, you see here this little pouch? That's the right atrial appendage, which used to be called right auricle. It has a triangular shape, and on the other side, barely showing, there's part of the left appendage. That one has an italic S shape, and it comes from the left atrium cavity. You see that these appendages, both right one and left one, are hugging these two big trunks. First, you have a big anterior trunk directing itself backwards to the left and up. That's the pulmonary trunk. Here you can see how it comes from the right ventricle, right? And just behind this pulmonary trunk, we can see the ascending thoracic aorta, how it is going up, backwards, and to the right. It will give rise to the coronary arteries. Here you see the left coronary and the right coronary. And posteriorly to this ascending aorta, that you see it growing behind the pulmonary trunk, it will form an arch. That's the arch of the aorta, which keeps growing upwards to the back and to the left. So those would be the main elements that you're able to see from the sternocostal surface. Now let's go to the inferior view. So if we rotate the heart, you are going to be able to take a look at its inferior view or diaphragmatic surface. In this inferior view, we find the sulcus. This is a sulcus that separates the atria from the ventricles, so it's the atrioventricular groove. That due to its relation with the coronary arteries that run around it, it's been given the name of coronary sulcus. You can observe here another deep wall, therefore another sulcus, covering the interventricular wall. That's the posterior interventricular groove that separates the left ventricle from the right ventricle. And in this view, you can see that it is mainly formed by the left ventricle and slightly by the right ventricle. You can observe that above the coronary sulcus, it's located the base of the heart. And because of how the heart develops embryologically, you know how it slightly rotates from right to left, the left cavities end up posteriorly, while the right cavities are going to end up on an anterior plane. Here you're looking at what would be the left atrium, and over here at the right atrium. So it is mentioned that the base of the heart is formed mainly by the left atrium and in a small portion by the right atrium. If we study the right atrium, here you can find the drainage of both superior vena cava and inferior vena cava. Here we have this portion, that's the superior vena cava. Here we can pass the forceps through. And here in this other part you have the inferior vena cava orifice. So superior vena cava and inferior vena cava. They are very big cavities that are directly draining to the posterior smooth wall of the right atrium, which receives the name of sinus venorum. Remember that these are all smooth posterior walls. Now the doctor has his thumb inside the drainage of the inferior vena cava, and he's also introducing the forceps inside the orifice of the superior vena cava. On the left side, you'd find the left atrium, where you'd also find the drainage of the pulmonary veins. Here, right superior pulmonary vein, and here, right inferior, left superior, and left inferior. They are all draining in the posterior wall of the left atrium. Here, the doctor has introduced the forceps inside the inferior pulmonary veins, and now inside the superior pulmonary veins. Okay, so this would be the important features of the diaphragmatic surface, that it's named diaphragmatic because it is related with the central tendon of the diaphragm. Now, if we go back to the first position of the heart, we'd have our sternocostal surface that we were talking about. Now, laying on the doctor's hand is resting the diaphragmatic surface, okay? From here, we can go to the pulmonary surface, which is this one. So we could rotate the heart this way, and you'd see the pulmonary surface. This pulmonary surface is looking slightly backwards to the left and will be related with the mediastinal surface of the left lung on its inferior lobule. That's why it's called pulmonary surface. And we're noticing that it is formed mainly by all of the left ventricle. Here the apex, the left ventricle, and on top of this we'd find the left appendage, used to be called left auricle, with part of the left atrium. Here you see part of the superior pulmonary vein, inferior pulmonary vein, both on the left side. So this would be the main features of the pulmonary surface. On this external configuration, to make the most out of it, we can also review the heart's irrigation. Here the arteries can be seen really well. You know that the main arteries that irrigate the heart are the coronaries, which are the first branches of the aorta, in this case the ascending aorta. Remember that on top of the origin of these coronary arteries, precisely above the sigmoid aortic valves, where there actually are some widenings, those widenings are the aortic sinuses. We have the left aortic sinus, where the left coronary artery originates, and here we have the right aortic sinus, where the right coronary artery originates. Let's start here at the right coronary artery. This right coronary originates from the right coronary sinus, and you see how it goes running towards the right, and it passes next to the pulmonary trunk. Here you see the right coronary artery, and it starts giving branches that will be going to the right atrium. One of these branches is a very important one because it will arrive to a structure that is just anterior to the superior vena cava orifice. We're taking the superior vena cava, and at this point we'd find the sinoatrial node. That's the heart's pacemaker, which is what will regulate the heart's frequency and is part of the electrical conduction system of the heart, which in most of the cases it's irrigated by the right coronary artery, and in a small proportion it's irrigated by the left coronary as well. If we follow the right coronary, we can see how it goes on the right side. It runs on the right side of the pulmonary trunk, and it keeps going over the coronary sulcus, over the atrioventricular groove, and it arrives to the diaphragmatic surface, and here on the diaphragmatic surface it will end up giving the posterior interventricular artery. So here we're looking at the posterior interventricular artery that will be the end of our right coronary artery. Before that, it gives some branches. For example, it gives a little branch that will go to the right border of the heart. That's the right marginal artery. And this posterior interventricular artery will irrigate the posterior portion of the interventricular wall. So we can review that our right coronary will directly irrigate the right atrium, part of the interior portion of the right ventricle, the posterior or inferior diaphragmatic surface of the right ventricle, and also the posterior third of the interventricular wall through the posterior interventricular artery. If we now go to the left coronary artery, we see that this left coronary is actually a trunk. Here you're seeing it. Because when this little trunk reaches the left side of the pulmonary artery, here's the pulmonary artery, when it reaches the left side of the pulmonary artery, it bifurcates in two branches. Those would be the anterior interventricular artery, which is going down the interventricular wall, over the anterior interventricular groove on the sternocostal surface of the heart, and a little posterior branch that is the circumflex artery. This circumflex artery goes over the coronary sulcus or an atrioventricular groove, but now on the left side, and it gives the marginal left artery that runs along the left border of the heart, and on some occasions it continues over the coronary sulcus. Here we can see it's hypoplastic, it's very small, and a lot of times see it in anastomosis with the posterior interventricular artery, that is branch of the right coronary. So you can see that the left coronary will irrigate the left atrium. It will irrigate a portion of the sternocostal surface of both left and right ventricles. It will irrigate the border or the pulmonary left surface. And it will also irrigate the posterior or diaphragmatic surface of the left ventricle. With all this, now you're able to see how anatomical variations exist. Over here we have another specimen, another human heart, where we can see anatomical variations. For example, here the pulmonary artery that looks so pretty. This pulmonary artery, if we look about 5-6 centimeters after its origin, it gives two terminal branches that will be the right pulmonary artery and the left pulmonary artery. And how the right pulmonary artery is running below the aortic arch. Here's the beginning of the arch of the aorta. So if we move the trunk of the pulmonary artery, we can see the ascending aorta that's behind the pulmonary trunk. And this ascending aorta given its branches. The left coronary, and over here the right coronary, okay? And here it is the right coronary. And if we take a look at the right coronary, we were saying that it goes from the right side of the pulmonary trunk, then over the coronary sulcus, and we see that actually this right coronary was very hypoplastic, and it ends up giving the right marginal artery. So possibly here it gives a little branch that maybe goes to the SA node, but normally the right coronary artery also irrigates the AV node that is located exactly at this point where the heart's crux is formed by the confluence of the interventricular groove, the coronary groove, and the intraatrial groove. About here is where the SA node would probably be, already endocardic inside the cavity of the right atrium, immediately on top and forward of the coronary sinus drainage. So this right coronary was very hypoplastic. Let's now see the left coronary. This left coronary, a little trunk first that rapidly divides into the anterior interventricular artery and the circumflex artery, later turning into left marginal, and look, here we can see how this left coronary, the circumflex properly speaking, will give rise to the posterior interventricular artery. Here we have a left coronary dominance from the left coronary artery. Here the venous structures, which are sometimes hard to dissect, would have to inject those venous structures, but here would be the place where the coronary sinus would be. And this coronary sinus is at the atrioventricular groove on the left side, meaning in close relationship with the left atrium. But you know that it will drain at the right atrium, right? And that it will receive the major coronary vein that will pick up blood from the left coronary, and it will also receive the minor coronary vein that will drain the blood from the right coronary, receiving the medial vein or posterior interventricular vein that will also drain on the coronary sinus. But stressing it again here, the coronary sinus cannot be observed because special techniques like plastic injection of the vessels would be needed for such purpose. Now we're going to see the internal configuration of the heart. So it's a pity, but we have to do it. Let's cut through the pulmonary artery so that we can jump into the right ventricle. Kind of hurts having to even just watch it, right? But look, here the doctor is cutting the pulmonary artery. Which almost immediately after its origin, there they are. Look how pretty. They are the sigmoid valves. There they are, really pretty, these sigmoid valves, which are the semilunar valves in this case of the pulmonary artery. They are 3, and they say they have swallow nest shapes. It looks beautiful. See on top they have a little dilatation that would be the pulmonary sinus, and here the sigmoid valve that would be 1 anterior and 2 posteriors, right and left. And they are important because they avoid the blood regurgitation when the ventricle relaxes. When the ventricle relaxes, the blood cannot come back to it from the pulmonary trunk thanks to the closure of these valves. So when the ventricle contracts during systole, these valves move up and close, and when the ventricle relaxes, they move down and stay closed, originating the second sound during the cardiac cycle, dub, what is called the sound during diastole. And this second sound that happens during diastole is given by the closure of the sigmoid valves from both the aortic and the pulmonary trunks. If we now continue cutting the anterior wall of the right ventricle, you will observe that this anterior wall of the right ventricle is formed of thin walls because it has to beat a low pressure offered by the vascular system, the minor or pulmonary circulation that doesn't have a pressure higher than 12 millimeters of mercury during diastole and up to 24 during systole. Very different from the left ventricle, that during systole the pressure is 120 and during diastole is about 80 millimeters of mercury. So if we open the right ventricle cavity, we can see here that it is as if we were getting inside some sort of caverns, as if they were Cacahuamilpa's grottos, right? Which are getting in blur shape for tourists. So look, there they are, the Cacahuamilpa's grottos, right? Anyways, the point is that there you are looking at the trabeculae carinae, which in the case of the right ventricle, they are less in number but thicker, while in the left ventricle, they are more in number, but thinner. And here what firstly calls your attention is that we see an arch. There is this little arch, which is some sort of a bridge. Here would have the interventricular groove. This bridge it goes from the interventricular wall to the anterior pillar, or the anterior papillary muscle. This is the septomarginal trabecula, or moderator band. That here it works as a scaffolding, so that over that bridge can run the right branch of the atrioventricular bundle or bundle of His. This, remember, that is part of the heart's electrical conduction system. It comes from the atrioventricular node, then comes the atrioventricular bundle, and this bundle divides in a right branch that goes to the right ventricle and a left branch. So the right branch runs exactly through this moderator band we're talking about. You can observe here at the back part of the cusps or leaflets of the tricuspid valve. There they are, And you see on top of the papillary muscles, there at the back, it's a papillary muscle. From its very top are emerging the chordae tendineae attached to the leaflets, to the tricuspid valve's leaflets, that are an anterior one, a posterior one, and a septal one. And they are important because they close the urine systole, originating the first cardiac sound, lup. So the first sound is the urine systole and is given by the tricuspid and mitral valves, lup, while during diastole it is given by the closure of the pulmonary and aortic valves, dup. There it is, so beautiful with the lighting from our fabulous camera. We're really able to see it, right? Here at the top, you are able to see a crest. That crest is going to be separating the outlet of the pulmonary artery from the entrance of the right atrium through the tricuspid valve. This is the supraventricular crest, which is really separating the inflow chamber, which is posterior, from the outflow chamber, which is anterior. So that means that while the blood circulates, it gives a rotation of about 140 degrees, okay? It enters from the right atrium's orifice, occluded by the tricuspid valve, and then it turns around 140 degrees and it lifts upwards and to the left through the pulmonary valve. So those would be the main elements that we can study here at the right atrium. Look, it's fabulous how it can be seen here, the papillary muscle, and from the papillary muscle emerging the chordae tendineae, and finally arriving up here at our tricuspid leaflets. Now let's get inside the right atrium. Now that we're here, to get into the right atrium, let's go to the heart's base. So here we have the inferior vena cava orifice and the superior vena cava orifice. Let's communicate these two orifices that are located at the posterior wall of the right atrium. In other words, the doctor is cutting the sinus venarum. Now we are inside the right atrium. If we open this right atrium, you're looking at it from behind. The first thing that calls our attention is that here at its lateral wall, the doctor is gonna take it with the clamp, you can observe that it is very rough, right? And that this roughness comes from a crest on top. Now the doctor's finger is pointing at the crest, and like teeth from a tooth comb coming out these creases. So the crest is the crista terminalis that on the surface forms the terminal sulcus that goes in front of the superior vena cava orifice and ends below and in front of the inferior vena cava orifice, because what we did now was communicating the inferior vena cava orifice and the superior vena cava orifice. You see the teeth from the tooth comb that come out of the crista terminalis? Those would be the pectinate muscles. So here you're looking at all the pectinate muscles, and they continue at the bottom of this structure that we were looking at in the external anatomy, the right appendage, or right auricle. So right now the doctor's finger is inside the right appendage, and you're learning that the right appendage is actually a blind-ending passageway or cul-de-sac, and that the walls of this cul-de-sac are totally rough because of the presence of the pectinate muscles. These pectinate muscles come right from the crista terminalis, okay? This crista terminalis forms the terminal groove that on top of the superior vena cava orifice is where the sinoatrial node or heart's pacemaker would be found. Now we'll go to the septal wall. This is the septal wall, and here in this septal wall it actually corresponds to the interatrial septum, that in the fetus they were communicated by the foramen ovale, but during birth that foramen ovale is occluded and forms the fossa ovalis. Remember that the septum primum meets the septum secundum, and then on the right atrium is left a fossa, the fossa ovalis. Instead of a foramen, it is now a fossa, a little fossa. Here we're looking at it. Look how nice it looks, how it has a folding here, and so it would be on the inferior posterior portion of the interatrial septum. You have here the fossa ovalis. Actually, this is one of the most common congenital heart defects, the patent foramen ovale. It is the interatrial communication, which on several occasions is asymptomatic, depending on the size of this communication. So here it looks like it maybe wanted to persist a little interatrial communication. Here it looks like there is a little closing defect of the foramen ovale at the fossa ovalis level. You can observe that forward, this cavity will be communicating with the right ventricle through the tricuspid valve. So at the bottom would be the tricuspid valve, alright? There at the bottom, let's try to get a better view. There we go. There are the cusps of the tricuspid valve, anterior, posterior, and septal. And then we would fall where we were a while ago, on the right ventricle. We can't curse here, but come on, how great does this all look, right? Okay, now we can go to the left atrium. And here at the left atrium, well, we can to enter the left atrium. Here, for example, it already has a cut made at the level of the right superior pulmonary vein. Let's make the most of it and communicate the two right superior pulmonary veins, the right one with the left one. So, having taken advantage of the previously made cut, we are going to enter the left atrium. The first thing that calls your attention is that its lateral wall is smooth, very different from what we were looking at on the right atrium that was very rough. They were the pectinate muscles with the crista terminalis. In contrast, this one is smooth, so what we would look for is the bottom of the left appendage. See, here it is the left appendage. The doctor's putting his finger inside of it, and here, beneath this, rugosities can be felt, which means that here it is the only rough place of the walls of the left atrium, that is at the bottom of the left appendage, so those are the pectinate muscles of the left appendage. And it is right here where more small thrombus are formed, particularly when there are alterations on the atrial contraction, that they don't contract in a uniform way, producing what is called auricular fibrillation. That is a disruption in the rhythm of the heart's contraction, and it creates a lot of turbulences in the atria, and this turbulence causes the formation of a small thrombus, meaning small clots attached to the walls of, in this case, the atria. And a common place where this happens is at the bottom of the appendages, and those thrombus can be freed and formed emboli. And if those emboli are on the right side, they will go occlude capillaries from the pulmonary circuit and cause pulmonary tissue death, which would mean pulmonary enlargement. And if they come from the left atrium, they'll go to the left ventricle, and they're from the left ventricle to anywhere in the body circulation. So, being systematic, it could cause brain enlargement, kidney enlargement, even an extremity enlargement, which would end up in necrosis, right? At the anterior bottom of this left atrium, you can observe there at the bottom the mitral valve. There it is, the mitral valve, which has two leaflets, one anterior and another one posterior. But also, sometimes accessory leaflets are formed. Here, as you can see, there are many accessory ones, which is really the common thing to find. Let's remember that when this orifice is closed or not completely open, it is called a stenosis. Here, it'll be a mitral valve stenosis, and when it cannot be properly closed during the ventricle systole, it is called heart failure. So, with an stenosis, there is difficulty on the outflow of blood from the left atrium to left ventricle, and such will cause dilatation of the left atrium because of the stenosis. And during heart failure, when the left ventricle contracts, blood backflows to the left atrium, producing a dilatation and a murmur during systole because of the failure, and a murmur during diastole because of the stenosis. right? Finally, we could enter the left ventricle. So on the left ventricle, we could make a cut over here, over the sternocostal surface. A cut of the left ventricle, which if you realize will get quite thicker. We're going to reach the apex, and here on top we're going to reach the coronary groove. The first thing that calls our attention, if you remember the thickness of the right ventricular wall, as you compare it with the left ventricle one, well, it gets a lot thicker, about 3 times. Look here at the thickness of this ventricle. It is as thick as a finger, meaning about 15 millimeters. Different from the other side, where it doesn't even reach half centimeter. So the left ventricle is 2/3 thicker, because it has to beat a greater pressure of about 80 millimeters of mercury during diastole. That is a pressure the aorta can offer. So here we're getting inside the left ventricle that has a larger number of trabeculoid carinae, but they are thinner. And here the first thing that calls our attention is a papillary muscle that is located on the anterior wall. So it's the interior papillary muscle. And behind it, it can only be barely seen the posterior papillary muscle. So there would be the posterior one and also the anterior one. And from the apex of these papillary muscles attached, the origin of the chordae tendineae that go from here on top to the leaflets from the mitral valve. There we have the junction between the chordae tendineae and the leaflets of the mitral valve. This is the inflow chamber that locates posteriorly. Where was the outflow chamber? We're going to introduce these forceps, and here they will take us to the outflow chamber. That, if you realize, it's continuing itself towards the aorta. There it is, that would be the ascending aorta. So the forceps are entering the ascending aorta. We're going to do a cut of the ascending aorta, up to a little bit above of the origin of the left coronary, so that you can see how the forceps are coming in, and you can see the sigmoid valves. Let's take out the forceps, and we're gonna open up the aorta like a book on one side and the other, so that at the bottom we can take a look at the sigmoid valves. See, there they are. They look amazing, right? These sigmoid valves. They would be 1 posterior and 2 anteriors, here in the case of the aorta, right? You already know that these sigmoid valves open during systole and close during diastole. This means that if there is an stenosis, a narrowing of the aortic orifice of these valves which are attached because of an infectious process, to say an endocarditis or rheumatic fever, if it's an stenosis, the murmur will be during systole, and if it's a failure, meaning a wrong closure, the murmur will be during diastole. This means the opposite of what happened with the tricuspid and mitral valves, okay? There they are, the sigmoid valves. Very good. Well, so with this, we would now have more or less an idea of the anatomy of our heart.